introduction there.
Recording in
So today,
progress.
guys, thank you for having me back. I spoke about genetics in April. We did a really big overview, and I apologize because I put so much information in that hour. This one's not going to be near as long. It's very focused. It's hereditary kidney cancer syndromes, and so we'll go ahead and get started. Let me get my, here we go. You can see my screen, correct? Okay. So I don't have any disclosures. Today's learning objectives are we're going to review kidney cancer facts. We're going to also learn about hereditary renal cancer susceptibility genes. Several of them we're going to really focus in on the top 5 listed there: von Hippel-Lindau, Birt-Hogg-Dubé, pheochromocytoma, paraganglioma, hereditary cancer syndrome, hereditary leiomyoma, renal cell cancer syndrome, and hereditary papillary renal cancer syndrome. We're also going to touch on a few other ones that are a little less common, but we should know about. By the end of the presentation, I'm really hopeful that folks can, recognize these syndromic patterns as well as understand the risks associated with these conditions and how to manage them. Oh, so this here is obviously a grossly dissected kidney. We see the kidney cancer up here. This is an example of an erosion into Garota's fascia. Another dissection, and here is the kidney cancer, but we can see a nice little layer of fat still around it contained within the kidney. So just reviewing kidney cancer staging really quickly. Fairly simple, to be honest. So, less than a 7 centimeter tumor that is contained within the kidney is a stage 1. Greater than a 7 centimeter tumor that is contained within the kidney is a stage 2. Stage 3, regardless of size within the kidney, the tumor has advanced into the local renal vessels here or into the inferior vena cava, additionally into maybe some regional lymph nodes. And then stage 4 is actually, invasion into the ipsilateral adrenal gland, invasion into Garota's fascia, or distant metastases. And so in reviewing some facts, most cancer, kidney cancer is sporadic. It occurs incidentally. About 5 to 8% of all cases are hereditary. There's been 19 genes linked to date. We're going to talk about 10 of them. Men have double the risk of women for developing kidney cancer. Smoking is by far and large the biggest risk factor. It's a 12-fold increase alone for developing kidney cancer, and a third of all cases of folks that are diagnosed will have a history of smoking. It's linked to obesity, it's linked to hypertension, some occupational environmental exposures, benzenes, herbicides, pesticides, diesel exhaust, asbestos, certain medications, more recently diuretics with chronic use, as well as in the past phenacetin, which was actually taken off the market back in the 1980s when it was found to have carcinogenic effects. That was an antipyretic and analgesic that was used over the counter back then. Now, long-term dialysis as well as renal transplant, those folks can develop acquired cystic disease of the kidneys, and that can predispose them to kidney cancer, as well as the immunosuppressive therapy that patients take after they receive a kidney. How does this present? We've seen it. It presents with flank pain, painless hematuria, or a flank mass. However, when patients have all 3, there's a pretty good chance that they may have advanced disease at the time of diagnosis. Many patients still come asymptomatic. We're seeing them because they went to the ER for something else, or they had, imaging for some other reason, maybe gallbladder, whatever the case, and it incidentally picked up a kidney mass. They may have weight loss, fever, night sweats, malaise. Rarely people present with paraneoplastic syndrome, and so we should know how that looks. Sometimes it's secondary polycythemia from an elevated erythropoietin. Sometimes it's hypertension that's secondary from an elevated renin. Sometimes it's high calcium, polyneuropathy, Shofer syndrome. I'm not sure how many people have really heard of Shofer syndrome, but essentially it is a non-metastatic hepatic dysfunction that is secondary to a primary tumor, usually a primary tumor from the kidney. So looking at the kidney cancer histologies, clear cell is the most common. 75 to 80% of all cases are clear cell. This is followed by papillary and then the less common histologies as well. But what I really wanted to focus your attention in on is the fact that sometimes the pathology can lead us to, what underlying genetic syndrome we might be having in front of us. So if we look at the first here, we have clear cell carcinoma, and that's associated with von Hippel-Lindau. Here we have papillary type 1, which is associated with hereditary papillary renal cell cancer and a MET mutation. The rarer types, chromophobe, oncocytoma, and hybrid of the two, are actually associated with LCN deletions and Birt-Hogg-Dubé. And then we have the papillary type 2, which is associated with FH mutations and HLRCC, which is the hereditary leiomyoma renal cell carcinoma syndrome. We can see medullary, which is very rare, sometimes associated in patients who have sickle cell trait or sickle cell disease. And then it's also related to the SMARCB1, which is a gene that can cause this so-called hereditary rhabdoid tumor predisposition syndrome. And essentially, those folks, unfortunately, in the first 2 years of life, present with these very aggressive rhabdoid tumors involving their brain, involving their kidneys. But later in life, they can develop medullary kidney cancer. They can also have some schwannomas and meningiomas as well. When we think about angiomyolipomas and we have multiple in a person, we always want to think about tubular sclerosis complex syndrome. Oncocytic are usually related to a mutation in one of the SDH genes. There's A, B, C, and D. And then P10-Cowden syndrome and see clear cell cancers as well as chromophobe. So NCCN has put together a really nice slide for us here talking about who's at risk, what's the eligibility criteria, but I summarized it there on the left. So early age of onset defined as less than 46 years old, bilateral or multifocal kidney cancer, having a kidney cancer in a patient and then them having a first or second degree relative with kidney cancer is a risk factor. The pathologist saying, hey, this kidney cancer is FH deficient or SDH deficient. And then also if the patient has multiple angiomyolipomas or if they have these fibrofolliculomas, those are things that clue us in as well that the patient may have an underlying susceptibility mutation associated with one of these hereditary syndromes. So this is just an overview because there is a lot of overlap of these genetic syndromes. And so I just wanted to kind of, before we get into the weeds of them, introduce them to you. And so VHL, von Hippel-Lindau syndrome, we keep it simple. It's the VHL gene. And again, clear cell carcinoma, often multifocal, often bilateral. Folks also have these hemangiomas and hemangioblastomas, which is probably the primary feature of VHL. Pheochromocytomas, paragangliomas, particularly of the neck, the thorax, and the abdomen. We also see pancreatic neuroendocrine tumors as well as pancreatic and renal cyst, and then endolymphatic sac tumors of the ear canal as well in those patients. All of these genetic syndromes that we're going to talk about today are inherited autosomal dominantly. So again, one parent has the mutation, 50-50 chance for passing to each child. Birt-Hogg-Dubé is next on the list. It is associated with a mutation in the FLCN gene. Features of that, again, those rare tumor types, but they can have a lot of lung cysts. They can also have spontaneous pneumothorax, often recurrent. Fibrofolliculomas of the skin is very common. The cancers that they also express outside of renal are going to be thyroid, colorectal, melanoma, and then they can get these parotid gland tumors as well. Now with HLRCC, again, hereditary leiomyoma renal cell cancer syndrome, that one is associated with a mutation in the FH gene. Features of that are very aggressive, and that's one thing you want to remember, type 2 papillary renal cell cancer, but they also have these leiomyomas of their skin as well as women in their uterus. Hereditary paraganglioma pheochromocytoma syndrome is associated with mutations in the SDH, BCD, and A genes. The thing with SDHA, or a lot of experts are leaning toward, hey, it's not a highly penetrant gene. And what that means is that we don't really see a lot of expression in patients who have SDHA of the features that are associated with the mutation. So essentially, we're not seeing high rates of kidney cancer or anything else in those folks, but we are seeing it with SDHB and D in particular. And so they have high risk for kidney cancer, paragangliomas, pheochromocytomas, gastrointestinal stromal tumors, as well as these pulmonary chondromas. And thinking back to our days when we were all in school, many of us learned maybe about Carney triad. And so that is your pulmonary chondromas, your GIST, and your PHEOs. And it is highly associated with this syndrome. Hereditary papillary renal cell carcinoma involves the MET gene, and it's associated with the type 1 renal cell cancer. These ones are more rare, so I'm going to touch on them just so that we introduce them to the group. However, you know, I only have a handful of each of these. TSC, tubular sclerosis complex syndrome, is due to mutations in TSC1 and 2. It's associated with clear cell kidney cancer. It's associated with those angiomyolipomas that I mentioned. Angiofibromas, they can have these hamartomas, hamartomatous polyps. They can have cardiac rhabdomyomas. They can have these like white macules of their skin, these shade greens patches that kind of look like this. So they're like little cobblestone, but flesh colored. And they can have those varying in size. Some can be quite large. Astrocytomas, they can have seizures, pits in their, you know, enamel. Fibromas in the oral cavity are another feature. But as far as the kidney cancer goes, we are doing MRIs very early on in those folks. We start at the age of 12. They have every 1 to 3 years for screening of kidney cancer. And we also plug them in with dermatology and neurology as well. So the BAP1 cancer syndrome is the BAP1 gene. Again, clear cell carcinoma is a key feature of it. These folks have high risk of melanoma, though, uveal, cutaneous, and you know, it's odd in that the uveal is there because most are cutaneous only, like the next one that we'll talk about. But interestingly, we can see malignant pleural mesothelioma in these patients also. So in those who have BAP1, we actually start a little bit later because the onset of kidney cancer is, you know, later in life. And so around age 30, they start MRIs of their kidneys, and they have those about every 2 years. We plug them in early with dermatology. They see them annually. They're seeing ophthalmology, and if they develop mesothelioma, thoracic oncology. The MITF cancer syndrome is associated with mutations in the MITF gene. And again, clear cell carcinoma is what it's associated with, melanoma of the skin, pancreatic cancer, pheochromocytomas, and paragangliomas. And so in addition to MRIs once a year, which we generally start around age 35 to 40, they're plugged in with dermatology. We screen for pancreatic cancer if we see it in the family. We talk to them about signs and symptoms of PHEOs and paragangliomas, and, you know, may remember some are sympathetic, some are parasympathetic. And so, you know, the sympathetic excess catecholamine release. And so they have all of those, you know, symptoms of apprehension, anxiety, palpitations. They may have like sweating, headache, and such. And so we monitor their blood pressure once a year. We are doing metanephrine testing every year. This starts very early in life, ages 6 to 8. They're getting whole body MRIs, you know, from the ages of 6 to 8. And then, like I said, we plug them into derm. Teach them good skin, you know, care prevention and such. So Cowden syndrome P10, I talked a lot about that in the springtime. So I'm just going to touch on it because it can be one that's in the mix for, you know, renal cancer syndromes. It's clear cell papillary or chromophobe. Again, it's pathognomonic for these folks to have macrocephaly. So their head circumference in men, when we measure it kind of around here, is 60 centimeter or more is a large head circumference for a man, and more than 58 centimeter for a woman. We also see breast cancer, thyroid, uterine, colorectal. So again, they're getting lots of things too. They're getting MRIs of their kidneys. They're getting ultrasounds of their thyroid, MRIs of the breast, mammograms of the breast. We offer them risk-reducing mastectomies and reconstruction. We let them have their children. Then afterwards, you know, we address the uterus. They often have lots of fibroids as well. And then they have colonoscopy every 5 years, usually starts around age 30. In terms of the hyperparathyroid jaw tumor syndrome, it's the CDC73 gene that's involved. This presents early in life too, often involves Wilms tumor of the kidney or other types of kidney cancer. The primary presentation, though, in folks with this genetic syndrome is hyperparathyroidism, but they are at risk for parathyroid cancer. Of course, the jaw fibromas, as the name implies, as well as uterine cancer. So we're talking about signs and symptoms of all of those things. Kids are getting ultrasounds quite frequently of their kidneys every 3 to 4 months until the age of 7, because that's when we're at highest risk for a Wilms tumor. In terms of hyperparathyroidism, I think we're all familiar, calcium, intact PTH, as well as vitamin D. If the calcium is ever super, super high, higher than you would expect with hyperparathyroidism, then that's usually indicative of maybe an underlying parathyroid cancer, of course, neck mass, something along those lines. So this is our first case. This is a patient. She's 27 years old. I met her 2 years ago. She came to me because her mom was diagnosed with pancreatic cancer at the age of 54. And in drawing out her pedigree, we learned that her maternal grandmother had kidney cancer at age 62. So the most suspicious person in the family was her mother. She meets NCCN guidelines for genetic testing based on the fact that she has a first degree relative that's had pancreatic cancer. So we went ahead and did a multi-gene panel, and we found von Hippel-Lindau. And so we counseled her, and we counseled her on the following. So one of the things with von Hippel-Lindau is there is near complete penetrance by the age of 60. So what that means is that folks who have this genetic mutation will express signs and symptoms of it by then. The cumulative lifetime risk for kidney cancer is somewhere between 24 and 45%. Probably on the lower end in people's family where we're not really seeing it expressed. We call that like the phenotypical expression of the gene. And on the higher end in people that have a lot of kidney cancer in their family. So some key things to know about this type of kidney cancer is it's often small, multifocal, or bilateral. It is of the clear cell etiology, but it is indolent, and so it's low grade, slow growing. And why that's key is on the next slide. We're going to talk about how these are managed. Other hallmarks, though, more than half of the patients will have renal cysts, and they can grow to varying sizes. They can have multiple, and those can become problematic for patients too and lead to need for surgical interventions and things. They can have pancreatic cysts. Pancreatic neuroendocrine tumors are about 15% risk. Hemangiomas, there's a range there, but that is the most common manifestation of von Hippel-Lindau syndrome is a cerebellar hemangioma, as pictured here. And then finally, the lymphatic sac tumors are something that we see as well, upwards of a 10% risk. So as it turned out, when I was talking to her about these features, it was like, oh yeah, mom told me that her pancreatic cancer was neuroendocrine. So how do we treat these people and manage them? From a kidney cancer standpoint, it's going to be surveillance with MRIs. Generally starts at the age of 15 or 10 years prior to the earliest onset in the family, whichever comes first. And we have those done every other year. We do follow the 3-centimeter rule for their cyst and potentially for an underlying cancer. So not that something might not be biopsied if it looks suspicious, but oftentimes the urologist will say, hey, we're going to watch this, closely. And then if it becomes larger than 3 centimeters, then that's when we will do a surgical intervention. And the reason that they do that is often these folks will need a lot of kidney surgeries in their lifetime. And obviously, the more nephrons that we damage, the higher the chances of having chronic kidney disease and possibly ending up on, dialysis and on a transplant list. So, it's really important to, spare as much of the kidney as we can. From a pancreatic neuroendocrine tumor standpoint, they have MRIs of their pancreas. Again, starts at age 15. It's done every other year. For the inner ear tumors, we are doing MRI of the inner auditory canal as well as auditory testing. We do that every 2 years. It starts at age 5 and goes throughout life, may drop it off around 65. For the hemangioblastomas, again, either retina or CNS. So we're doing dilated eye exams, and they are having MRIs of their brain and spine. And the eye exams start very early in life. The MRIs start again around age 8, though MRI is every other year. Pheochromocytomas, paragangliomas, again, we're talking about all of the signs and symptoms so that they're aware. And they are having biochemical testing at least annually, and that starts very early, as you can see, ages 2 to 5, somewhere in that window. And then we monitor blood pressure. Just a little tidbit on this. So VHL can be autosomal recessive in that if both parents have a mutated copy of VHL and have children, each child has a 25% risk of inheriting both bad copies from each parent. And then that's a whole different condition. It's called autosomal recessive FE2 or familial erythrocytosis type 2. A lot of people are involved in their care: neurosurgery, ophthalmology, audiology, endocrinology, ENT. But I listed out some things here that can, unfortunately happen to these people as they go through life and develop some of these problems. So they can develop visual impairment, chronic kidney disease, adrenal insufficiency, diabetes, and then, of course, neurological problems with motor and sensory deficits. So back to my case one, my 27-year-old. So when I met her, she had her MRIs, MRI the pancreas, MRI the kidneys, and it saw cysts in both places, not surprising. However, in addition to these cysts, which we knew about, the radiologist had commented, hey, in the tip of the Usenet process, there's actually a 1 centimeter hypermetabolic lesion, and that's this thing here. And so I sent her for an EUS and a biopsy, and it did come back with a well-differentiated neuroendocrine tumor, grade 1, plugged her in with medical oncology and surgeons as well. And they're actually watching it closely, and she got pregnant in between as well, but everything is going good, and so far, so good. So this is a patient that came to me. He's a 40-year-old male. His brother was diagnosed with thyroid cancer at 30. That's one of the reasons that he was referred. And then he had a paternal uncle with thyroid cancer at 61. He had a paternal uncle with kidney cancer at 57, and then a grandfather with colon cancer at 49. Other than that, not much going on mom's side. So we did offer him a multi-gene panel, and it did show an FLCN Birt-Hogg-Dubé. This gentleman was a 48-year-old who was diagnosed with bilateral kidney cancer, synchronous. So whenever they did the biopsy, they saw that this was a rare tumor type, oncocytic, on both sides. When we looked at his family history, his mom had bladder cancer at 65, and then he had this maternal grandfather with pancreatic cancer at 65. So again, it's highly suspicious for Birt-Hogg-Dubé, but could be a number of other things as well. So we did genetic testing, and it also confirmed Birt-Hogg-Dubé for this gentleman. He doesn't currently have any expression of this. It's more his family. So Birt-Hogg-Dubé, it's something that often these folks will have, like these fibrofolliculomas of their skin. They're generally painless. Lung cysts are very common. A lot of times folks will have like these spontaneous pneumothorax in their family. They're like, oh yeah, so-and-so had a collapsed lung. Some people may not attribute it. As I talked to this gentleman about all of the risks associated with Birt-Hogg-Dubé, he did point out, well, my dad had that glue in his lung because of multiple lung collapse. So we talked through those things. The manifestations of the kidney cancer, again, the rare tumor type, but it is also indolent and so slow growing. Again, multifocal bilateral, the kidney cancer lifetime risk is up to 41%. And we can see other cancers in these families, which we saw in his. We saw thyroid, we saw colon. You can see melanomas and then these parotid gland tumors. So we talked to them about all the signs and symptoms of those. From the kidney cancer standpoint, again, it's MRI, active surveillance following that 3 centimeter rule. And that starts about age 20. It's done every 1 or 2 years. From the lung standpoint, I educate them on signs and symptoms, obviously, of a pneumothorax, but also we talk about, what puts us at higher risk. So, hopefully they're not people that are, wanting to scuba dive or, skydive, those kind of things. But even technically a prolonged flight is a potential risk factor. And so one of my patients who had Birt-Hogg-Dubé was actually a flight medic. And so we had to talk through if that was maybe the best career choice for him. As far as the skin cancer and the benign fibrofolliculomas, they do see dermatology at least every 6 to 12 months. Most people with bird hog dubé do have these fibrofolliculomas, and they're kind of like small little flesh-colored lesions that are throughout the body. Often they have them multiple on their back, multiple on their neck, their face, and so forth. From the thyroid cancer, they're going to get an ultrasound once a year. From colorectal cancer, it starts around age 40 that they're going to get a colonoscopy every 5 years. And then again, signs and symptoms of parotid tumors. And we tell them, to come in once a year for an exam. So this patient was a 32-year-old male that had a history of kidney cancer diagnosed 2 years earlier. It was papillary type 1. We went ahead and looked at his family history. It's pretty non-contributory. There was a maternal aunt that had lung cancer. Ultimately, his genetic testing did confirm as suspected, given his early age of onset and type 1 papillary, that he had a MET mutation. So MET gene mutations are associated with hereditary papillary renal cell carcinoma. Again, autosomal dominant. The manifestations are bilateral, multifocal, early age of onset. And then the other thing is it's a kidney limited disease. There's really not much else that it puts us at risk for outside of that. These are often indolent as well. So that 3-centimeter rule applies for surveillance. They're getting MRIs of their kidney starting at age 30. It's every 1 to 2 years. This is a gentleman that I had been referred from his dermatologist. He's a 67-year-old. He had this painful skin lesion. It was biopsied. It showed a cutaneous leiomyoma. Now, obviously, those are not very common, and the dermatologist was pretty in tune with genetics and said, hey, you need to sit down with someone. As it turned out, when we drew out his family tree, there wasn't a lot going on other than that nephew, his brother's son, who had kidney cancer at an early age. So we offered him a multi-gene panel, but obviously was mostly concerned with an FH mutation related to HLRCC, and that's ultimately what we had found. So hereditary leiomyoma, renal cell carcinoma syndrome. The key here is it's very aggressive. They grow rapidly, and even the tiniest lesions are prone to early metastasis. And so it's really important to be up on their surveillance and, just have them, I even do like urine analysis in these folks, monitoring for any kind of signs and symptoms of blood, in addition to their MRIs. Key other features are the paragangliomas, the pheochromocytomas, and then of course the leiomyomas of the uterus, in addition to the skin that we mentioned. Again, surveillance, MRI of the kidneys, starts at 8 years old. They can have early onset kidney cancer. The leiomyomas of the uterus, we plug them in with gynecology around age 20 if they're not already established. And then after their childbearing is complete, we do talk to them about hysterectomy. From a cutaneous leiomyoma standpoint, they're just having full body skin exam every 1 to 2 years with dermatology. And if they're painful, they are getting excised, or if they don't like them. Pheochromocytoma, paraganglioma, again, we're monitoring all the signs and symptoms, doing biochemical testing, and then MRI skull base to pelvis, and that starts early in childhood. And this is an unfortunate young man. He was 26 years old. I saw him last year. He's fairly healthy. He just had like a history of smoking, 1 pack per day for 8 years. He had a new onset of high blood pressure, and he's young. His BMI was 18, but he had presented to the ER with acute onset back pain and hematuria. It was only present for a week. And he's like, hey, this happened to me right after I was doing all this heavy lifting at work. So the ER went ahead and did this workup, and that led eventually to a CT scan, and unfortunately found a large over 7-centimeter left renal mass and bulky lymph nodes. This led to oncology, doing a PET scan and a biopsy. And so we can see this big renal tumor here with the METs. We can also see that he has cervical spine metastasis. He has periaortic metastasis and some lung involvement. He did the biopsy of the kidney, the primary site there, and it showed renal cell carcinoma with the FH gene deletion. And we did confirmatory testing mostly for his family. Karis also saw this somatic mutation as well. And his family is now undergoing genetic testing since we confirmed that he does have this hereditary leiomyoma renal cell carcinoma syndrome. So very, very aggressive. This is a patient, 57 years old. I saw her after she was diagnosed with breast cancer at that age. 3 years earlier or 4 years earlier, she had kidney cancer, but there was a strong family history of breast cancer in sister and mom. So we did offer her a multi-gene panel. She had two primaries, and we're really worried about something that would be attributed to an elevated risk of breast cancer. But what we found was that she had an SDHD mutation. This patient is a 46-year-old female. She came to me because her mom had early onset breast cancer at age 48. Other than that, there was a maternal grandmother who had stomach cancer at older age. Her dad had melanoma, older age. Nothing else was significant. Her mom was the most suspicious. That's where she qualified for genetic testing. And her genetic testing showed this SDHA mutation. And so SDH deficient renal cell carcinoma is associated with hereditary paraganglioma pheochromocytoma syndrome. The SDH germline variants do increase the risk for, as the name implies, PHEOs, head and neck paragangliomas, specifically gastrointestinal stromal tumors. Those are probably the biggest features. SDHB is the one where we see the most risk of kidney cancer, somewhere between 10 and 15%. But the kidney cancer that they develop, unfortunately, is aggressive as well and can metastasize early. And so it's important to screen these folks. And so we follow very specific protocols in children as well as adults. And we treat everybody the same based on guidelines. That said, experts are saying, hey, we might be doing too much for people with SDHA, maybe more harmful than good, since we're really not seeing a strong expression or penetrance of that gene. So we do the biochemical testing. We are, looking at their MRIs. We actually do like a full, a whole body MRI. Luckily, we have that here in Morgantown now. And so otherwise, you have to do all these sittings. You have to do the head, the neck, the abdomen, the pelvis, and such. So it's a lot for patients. So we do these questionnaires with patients looking for signs and symptoms of PHEOs and paragangliomas and see if there's any additional workup that we need to do in between their every 2 to 3 year MRI. This is my last slide. I'm not going to spend a lot of time on it. I just wanted you to know that NCCN does have a specific treatment that is recommended for patients with hereditary renal cell cancers. And so my young man that was 26 years old with HLRCC is currently on erlotinib and bevacizumab, and he is doing very well. And I am open to questions. Thank you.
All right. Thank you so much, Kristen. That was a really good presentation.
Oh, you're welcome.
Right. Does anyone have any questions or anything they want to discuss?
Thanks, Gina.